came from us expanding our program. So our program, we work with adults with developmental disabilities. We started out in August of 2012 with a program that was art-based for adults who were graduating out of the school system. And since then, in the 11 years we've been doing this, seems like yesterday, we have continually tried to add more training opportunities and more true to life work experiences for the people that we work with. So during the pandemic, we applied for the mini grant, and we're very grateful to receive it because we needed to move. And moving during a pandemic is, as you can imagine, a little bit crazy, but it worked out really well. We found a fully accessible space in Carver. We had been on the waterfront in Plymouth, and the space we were in was not going to be able to be updated to be accessible. And we didn't want to turn anyone away ever. So we found the space in February during the midst of the pandemic, and we had to do construction and we had to move everything over here. So the mini grant was very helpful for us. It helped in part of the expenses of construction and moving, and creating a second business model to work with the people that were already attending. So what I decided to do, instead of creating a PowerPoint, because I'm not good at that, I decided to take you on a tour of our new facilities, and so that you could see the impact that we are having with the community and on the environment. Because what we do is we create art that is upcycled and recycled, but on top of that, we added a refillery. And if people are not aware of what a refillery is, I'm going to show you. It is kind of cutting edge right now in environmental businesses, and it is helping the community to upcycle, recycle, and stop buying single-use packaging. So everyone in this community is super excited about it. We're trying to get the word out to the whole Plymouth area that we're here. And it's a great new training method to teach the people we work with business skills, retail skills, and all the other things that they're interested in learning, inventory, customer service, and that kind of thing. So it benefits them, but it's also benefiting the community and helping people to eliminate all that waste. So I'm going to take you on a tour. I hope you can see well. If you can't, definitely say so. So I'm going to flip my phone around and try to walk slowly and not make you dizzy. So right now, I'm going to take you into the store. So this is the Zero Waste store. What we say is we call it their store. It is not my store, it is theirs. And in a Zero Waste store, we carry all kinds of supplies that help on a zero waste journey, eliminating packaging, carrying a zero waste lunchbox, all those kinds of things, so that you're paying for products and not packaging. And then I'm going to take you around to, this is the chalkboard that tells our customers what we have to refill. So we refill every product that we carry in a liquid or a powder or a cream or a lotion. We refill that. You can bring any kind of packaging you want. to have refilled. Or you can pick something because we always have free packaging. And we also have refilled 551 containers so far. In a lot of zero waste stores, they will put the bulk product out in the store for the customers to refill. We don't do that. We have it in the back in a special area. And that is because the people we work with, that's another skill for them, another business skill. So they're learning how to do the refills and weights and measures and all those kinds of things. So we have all kinds of products that you can refill. We have local products. We try to source the majority of our products locally, but some are products that come from outside of the area, but they're all products that are organic, and they're all products that we try to source from women-owned business, businesses run by people of color, also businesses that are veteran-run, and other nonprofits that create product. So that's a big part of what we do. It is entirely wheelchair accessible, which is a wonderful thing for us. We've never had that before. Some of the products within the store we actually make. So we make organic wool dryer balls. We just finished a large order of 306 dryer balls, custom order. And we carry a lot of those things you will see advertised recently. Laundry sheets that you see advertised, we carry those. You don't ever have to buy a package. You can come and just buy sheets. And then all kinds of other things that help with a zero waste lifestyle. I'm going to take you in the refillery. Oh, we also have this wonderful local vendor who does honey and sauces, and she also does fresh bread for us. This is our cash register system. So this is very important to the people who come here. That we did use part of our grant to pay for upgrading the cash register system. We have a system that works with photos. So if we have people who are not good readers, they can go by the photos on the system to check you out. These are the freebies. There's always free containers. So the refillery, this building was a bank, which was wonderful. We reused most of what was here. We didn't take it out. We even reused studs when we were building. So in the refillery, they weigh things, they take the weight of the container off, and then they refill it with new product. We have a 40-foot counter of refillable product and all organics. And our very first 50-gallon drum, that was very exciting. That's the most popular product, unscented laundry detergent. And if that's one of your pet peeves where you have to throw away all of those huge containers after emptying laundry detergent, you know how we feel. So you don't have to do that. And everyone's learning this system of refilling and weighing and the customer service involved. So that's a wonderful part of what we have. We also kept all the desks from the bank, so we don't have to install standing desks. They're already here. I'm going to take you around the corner into the gallery. So to have this accessible space to the gallery is something we did not have before. There were stairs, and we had to turn people away from classes because they couldn't have access to our space. Now everybody can be included. So this is where the people we work with create their art. They create all kinds of things. And the space that exists has allowed us to give them each a mini store within the gallery, so that their products that they create or their art that they create is available all in one spot. And it's light and bright and open, which is a
Yeah.
wonderful thing. Yep.
Yeah, I was just gonna ask about how many folks you have who work there or come in and do, you know, their own art there? About how many different folks?
We have 12 people. We are very close to becoming a CBDS program with DDS, with the state of Massachusetts. And so we'll be expanding the number of people. And we also have integrated classes, so the community can come into any of the classes that we offer. So we have yoga. We do yoga tonight.
So you have 12 now, and if you do expand, or if you're able to expand, about how many could you accommodate?
We're hoping a total of about 30 people.
Great.
Yeah, 12 to 15 people on any given day.
And where exactly in Carver are you?
We are at 160 North Main Street, which is Route 58.
Okay.
And we're in the Carver Marketplace. So this is some of the art. It's nice, we have parking.
Yeah, that's always good. Just sort of a logistical question on the refillery. Is there any limitation? I mean, are there any certain types of containers that are better to bring in, or does it just kind of...
You can bring any kind of container you want.
Okay.
As long as it's clean and dry.
Okay.
On the outside. Doesn't even have to be clean and dry on the inside.
That's great.
Here's our master jeweler.
And how much bigger is this space than your previous space?
It is double the size.
Okay. Yeah, I don't
think
I'd ever been inside the old space, but I definitely had driven by or walked by, and it looks a lot smaller than this.
Yeah, and it didn't have windows, and
Yeah.
it wasn't open and bright like this space is. So this is a lot more conducive to creating art.
And last question for me, did the bank leave behind any free samples?
No, we couldn't figure that out. We looked everywhere. Not a single penny. They were
Awesome.
very thorough.
Does anyone else have any questions or thoughts or comments? I'll take the spotlight off so you can see everyone as well. Go ahead, Jen.
I had a question about the hours that you're open.
Yes, so we are open Tuesday through Friday, 11 to 6, and Saturday, 10 to 4. It's very untraditional program hours, but we want it to be as close to, you know, a real life situation, a retail situation where you don't work 9 to 3. And so we can do more than one shift.
Great. I was writing all this down because I have a friend that's very interested in all the reuse, and I noticed you have his shirts in there, the reuse.
Oh, you have Alex?
Yeah.
Yeah, we've known Alex for about 10 years now.
That's great.
And he has done some programs for us, and we also carry his shirts.
Awesome.
And I just put the website in the chat so folks can...
Oh, thank you. We have more than one website. We have an e-commerce website, which is not totally up and running yet because we don't have a big enough staff to do all the shipping. that's required with that, but it's ready. It's there. You can look on it to see what our products are.
Well, this one has the address and the hours and all that, sort of the basics, So
Yeah,
it's good.
newagainink.org.
That's the one I put in, yeah.
That's our informational website.
Yep.
So you can look at the program, and then refill-able.org is the e-commerce. So you can see what kind of products we carry.
Excellent.
Gail, thank you for the virtual tour. I feel like that was so much more interesting than just a PowerPoint or something. So I thought that was a cool addition. Yeah.
Yeah, I wanted to have you tour in real time, but it's, it's not really the best thing at the moment. So
no, it was great. Once the video
work.
got pinned, it was like we were walking through. So thanks.
Good. Glad I didn't make anybody dizzy.
And thank you to Kelly for telling me to make it on Spotlight so everyone can actually see the tour. And,
Good.
Kudos to me for figuring out how to put on the Spotlight.
I don't know how to do that.
Only been doing this for 3.5 years on Zoom, but we'll figure it out eventually. All right. Well, Gail, thank you so much. We really appreciate the report back, and it's always great to see good programs and worthwhile ventures doing good with the funds that we've been able to distribute. So thank you for taking the time this morning. We appreciate it.
Thank you.
All righty. So I keep muting myself. I don't know why. With that, we will turn it over to our main speaker, Pam Bolorino from Child and Family Services. And CFS is the vendor or the contractor that was selected to oversee the new community behavioral health centers here in Southeastern Mass. And behavioral health is something we've been talking about for a long time, and we certainly are excited to see that these centers were open and hopefully adding more resources for the folks in need. And I think it's good timing to have you come, Pam, and talk about what's going on at the CBHC. So I'll turn it over to you.
Thank you. Thank you everyone for having me. I do have a PowerPoint. I don't tend to follow it. I tend to just kind of go on my own path, but I will share it just so that you have something to look at in regards to like getting phone numbers down and addresses.
You should be able to share, Pam.
Let me see. Let me see if it lets me share this way. I think I need to shut everything off so that it's just the PowerPoint that I have up.
So this is like the Zoom equivalent of when you're in person and you can't get the speaker or the projector to work with the screen.
I got it.
Real life. Here we go.
I got it. All right, let me just make this a whole. All right, everybody can see this?
Yep.
Okay. So I don't know if many of you are aware, but the CBHC was actually started on January 3rd of this year. So for many, many years, there was a lot of discussion in regards to how do we put services in one place where it's like a urgent center for someone who needs to go from a couple of stitches. But now we're focusing on mental health. Where can someone stop in without making an appointment if they're not feeling okay and they just need to talk to someone? We take for granted the fact that we are so aware when you're in the field of where to go for services, who to call, but majority of people don't know that. So by having a community behavioral health center, they now know there's like an urgent care center for services, and they don't have to stress about trying to figure out where the services are. So we actually, at Child and Family, we're very fortunate. We were awarded 2 community behavioral health centers, and we have 3 separate sites. So the primary community behavioral health center is actually, let me see if I can get this thing to Okay. The primary one is the Southern Coast. So the Southern Coast is, covers all the way from Dartmouth all the way to Hanson, Mass. So we have our main office, which is actually in New Bedford, and that's also where we have 2 units, which I'll talk a little bit about. And then we have our second site, which is in Plymouth. So New Bedford and Plymouth are one CBHC, and they're the Southern Coast. And then we have our Fall River site that has their own CBHC. So with the CBHC, there's 2 different components to it. There is the open access piece, and then there's the mobile crisis piece. And I'll get into that a little bit more just so folks understand what the differences are. So as you can see, we cover a lot of areas. Prior to becoming a CBHC, we always covered the Southern Coast part as a mobile crisis team, but then on January 3rd, we were awarded the Fall River team as well. So the community behavioral health centers are opened 7 days a week, and that includes open access. So open access is 8 a.m. to 8 p.m. and then 9 a.m. to 5 p.m. Monday through Friday. And then in addition to that, there's the 24-hour program, which is the mobile crisis team. So again, we have 3 sites. We have the 965 Church Street, which is our main hub. And then we have 61 Industrial Park in Plymouth. That is our Plymouth site. And then 1052 Pleasant in Fall River. The Plymouth site is a little unique. So when I talk about the CBHC, we own the best way, we own the contract, right? So we own the contract for the CBHC, but some CBHCs that didn't have clinics in the sites that they opened up, they were able to subcontract open access with a different agency. So in Fall River, we didn't have to do that because we had a clinic already through Child and Family in Fall River. So we just had our own CBHC out there. In New Bedford, we didn't have to do that because we already had a clinic in New Bedford. So we just merged both. But we didn't have that in Plymouth. In Plymouth, we only had the mobile crisis team. We didn't have psychiatry. We had all that, but it was all out of our New Bedford site. So we didn't have therapists. We didn't have psychiatry. We didn't have nursing, none of that. So we contracted out with High Point Treatment Center to be our open access. So what we did is we actually moved our mobile crisis from South Meadow to 61 Industrial Park so that we're in the same building as open access. Even though we subcontracted with High Point, we are the CBHC. We manage that whole entire contract, and we have to meet regularly with High Point because they have to report to us what they're doing. And we have to make sure that they're following the guidelines of CBHC, and we have to hold them to a certain, to a very high standard of what the expectations are, because we have to report all of that to the state. So our vice president of open access out of New Bedford, we also oversees open access in Plymouth as well. So what does the CBHC mean? For those of you that keep hearing about the community behavioral health centers, what does that mean? So this is the part where I tend to venture off from the PowerPoint. So the best way to describe it is there's one door. Even if there's 2 doors, one for open access, one for mobile crisis, you don't have to worry about it. No matter which door you walk into, there is no wrong door. So you walk in through the door, and I'm going to give you easiest case scenario. Somebody is suffering from depression. They really are struggling. They don't have a therapist, and they feel like they're getting progressively worse. They find out about the community behavioral health center. They walk into open access. Upon entering to open access, they're going to be greeted by a care navigator. That care navigator is going to meet with them. They're going to do a really short assessment to try and figure out what's going on with this individual. And based on that assessment, they make a decision what the next step is. So the next step could be that this individual actually needs to see a clinician. So they might be able to see a clinician right in that moment, or they might have to come back maybe at 1 o'clock. Most of the time it's in the moment, there's somebody available to see them. We keep part of our clinicians open throughout the day purposely for walk-ins. And then while this person's meeting with the clinician, they figure out that this person's really not doing well and they really should get placed on medication. And this isn't something that they want to wait for because the depression is so significant that potentially they might have to go inpatient if they don't get on medication relatively quickly. So we have what's called urgent psychopharm. So within 72 hours, that individual is able to see a psychiatrist at our site. The urgent psychopharm is something that we are very cautious about, in the sense of, when we do talk about urgent psychopharm to the community, we have expectations of what meets an urgent psychopharm, because we don't want to overuse it and not have those appointments available for folks that actually need it. It is truly meant for someone who either has, was seeing a psychiatrist, and then all of a sudden their psychiatrist left or retired, they didn't get a new one, and then all of a sudden they're running out of medications. Say they're, schizophrenic. If they don't continue on their medications, they can deteriorate significantly. And they need their meds within a couple of days. So then that would be a bridge appointment, and our psychiatrist would be able to start them on something. Or a mobile crisis sees someone and says, ooh, if this person doesn't see psychiatry within the next 2 or 3 days, they're most likely going to have to go inpatient, or go into the community behavior, into our CCS unit, at which point then I can approve a urgent psychopharm. So that's why I say I'm really cautious about disclosing about the psychiatry piece, because we want to make sure it's truly safe for those individuals that absolutely need to see psychiatry urgently. So that's one of the other things we do. So we offer the Care Navigator, we offer counseling in the moment, and we also offer psychiatry. But we also offer, which is really exciting, we offer recovery coaches, we offer peer specialists, we offer family partners. We offer groups. The groups are drop-ins. You could either be a client of Child and Family or not. There are some groups that are open to the community. You don't have to be a member of Child and Family Services. And the open access really tries to focus in on, how do I stabilize this individual? I call it the Band-Aid. How do we Band-Aid someone until we can get them into the long-term treatment? That's what I call it. How do we provide the service to this individual and get them stabilized enough so that when their appointment is, available for counseling or psychiatry that's going to be able to see them long-term, we can stabilize them until they get to that appointment. And that's why I call it a Band-Aid. It's truly making sure that we provide what someone needs to be successful in the community until they get that long-term. So the best way to describe it is our Plymouth and New Bedford sites are the easiest ones to describe. If somebody walks into open access and they're seen automatically by a care navigator, they go through all of these things. And it might just be like a 14-year-old child who's struggling in school, who's being bullied. And we might say, you know what, you might benefit from our youth group. We have a group at night for kids your age. This might be a huge, it might not even be that this kiddo needs counseling or anything like that. They might just need to be around other peers that are struggling with the same thing. Or, we have someone that is, in recovery and they're struggling with recovery, and they are starting to see the signs and symptoms that typically happens right before they relapse. So our recovery coach is going to support them. They might provide them with some support groups. They might just meet one-on-one with them. So they do very specialized services for that individual to ensure that they are doing okay. But unfortunately, not everybody's able to just do open access. Some individuals walk into open access and they truly are in crisis and they're not able to stay stable. So the care navigating team in open access will actually walk the individual down to mobile crisis. So in Plymouth, they'll bring them upstairs. Mobile crisis is upstairs, open access is downstairs. And in New Bedford, they just walk them down the hallway. And what they do is when they bring somebody over to mobile crisis, they do a warm handoff. So they will do just a brief description, like, met with this individual, here's what's going on with them. We really think they need a crisis assessment. At which point the crisis team then takes the case over and meets with that individual and assesses for safety, and then makes a decision of what to do from there. And sometimes what to do from there could actually be going back to open access, because not everybody needs a really high level of care. What that individual might need is to really talk about why they're in crisis. And the crisis team is trained to work through that and see what other solutions are there besides having to go to a higher level of care. So they might say, you know what? it looks like you do need psychiatry and you need it pretty quickly. So let's get you into urgent psychiatry. Or, you do need to see a counselor right away as well as psychiatry. So let's get you over there, get you to see someone right away as well as psychiatry. And then unfortunately, there are times that that's not an option. So we might have to look at like a partial hospitalization program, so a PHP. We might have to look at an IOP for someone. So we always try to think of outside the box. What else can we offer that individual? I've always trained my staff that when you meet with somebody, always consider the least restrictive environment before you get to an inpatient psych option. What are their resources? What are their supports? What are their triggers? And who out there can support them to keep them stabilized? And if you're able to develop a really good safety plan with support systems around this individual and offer them like outpatient options to keep them stable, that's what we're going to do. But it doesn't always work. So for the individuals that are not able to be back out in the community because they can't stay safe, we then have 2 units. We have an adult unit and we have a child unit. Our adult unit is for ages 18 and up. The 18-year-old has to be out of school in order to go into that unit. And then we have another unit, which is for 18 under. So an 18-year-old that goes into that unit is somebody who's still in school. The units are located on a New Bedford site, but they are, open to all of our 3 sites. We try to fill the beds up with the individuals that we service within the community that we cover. But if we don't have a lot of referrals, we will open up to other providers throughout the state, but we always focus primarily on our patients first as much as possible. So the units are voluntary. They're voluntary for the adults, the kids not so much. It's voluntary for their guardians and parents. And our adult unit is a 12-bed unit. We are licensed to take 12 adults, male and female. And our kid unit, we have a 15-bed unit. Currently, we're licensed for 12 beds because we were originally 9 beds. Then we went to 12, and we're gradually going to get to the 15. But we opted to just be licensed for 12 right now to get ourselves comfortable with a higher number, and then eventually going to 15. The adult unit does have some private rooms and then a couple of rooms that are actually double beds. And then our kid unit, it's all private rooms. I say 14 to 18, but our license allows us to take under 4. And, just the other day, we were looking at a 3-year-old and figuring it out, like, can we take this 3-year-old? And it's not an age group that we typically take because we have a lot of questions. They have to be able to, do their own ADLs. If they're not potty trained, it's not something that, we can handle on that unit because we're not equipped to do that. So there's those questions that come along with a 3-year-old that don't necessarily come along with someone 4 and up. The units are very structured. They have groups throughout the day. They have clinicians on site 7 days a week. They have psychiatry 7 days a week. They have nursing 24/7. And they have mental health workers 24/7. And throughout the day, it is a very structured setting. So the adult unit has structured groups, including some recovery group, as well as mental health groups, some coping groups, all sorts of different things that happen throughout the day. And we're also a smoke facility. As much as I hate it, it actually our adults really do appreciate that they can go outside and have a cigarette. So we do have an area in our yard where our folks are that they can actually smoke, but we have specific smoke times, and we tell them that from the beginning. And our kid unit, even though it's 4 to 18, it is split in half, meaning that up to the age of 12, that is one group. And then 13 and up is another group. So we're licensed for 6 under the age of 12 and 6 over the age of 13. Prior to becoming a youth crisis stabilization unit, we were a CBAT, and CBAT, we took kids of all ages and they intermingled. So the older kids were with the little ones. And I found that to be really beneficial to have the older kids with the little ones, because sometimes when the little ones are struggling and they're having a tantrum, and the older ones tend to sit there with them and talk to them and it's therapeutic for themselves as well as it is for the little ones. But the way that we're DMH licensed, and it is a split license. The downfall of that, which we've been finding, is if you have 6 kids under the age of 12 and you have, say, 4 kids over the age of 13, you have 2 open beds. But if all your referrals are for the under the age of 12, those beds stay opened. So we cannot fill it with anyone under that age group. The same exact thing. If we have 6 beds over the age of 13 that are full, and only 4 beds under the age of 12 that are full, we have 2 empty beds, can't fill it with anybody over the age of 13. So that has been a huge obstacle that we have found since being a YCCS. Everything else about the YCCS, we really do appreciate and we think it works really well. The age piece is a big piece, and we've been finding that since the kids have gone back to school. In the summertime, it wasn't so bad. We had a little bit more flexibility because the referrals weren't so high, but now that kids are back to school, we absolutely are feeling it. We are feeling it. We had an empty bed for 4 days because we could not get a referral for that age group and we couldn't fill it. We had referrals for a different age group, but we had to just keep an empty bed because of the way that the license works. So that's one of the deficits of it. So if you see like, Amaba or one of those sites, like we have an open bed, it doesn't necessarily mean that we can take that child. It's specifically to an age. So the mobile crisis team actually determines who goes into these units. So they complete a psychosocial assessment, and then they review it with their administrator on call, and then they make a decision if the person is safe to go onto the unit. The unit is able to handle some what we call soft detoxes. So if you have someone, that's a dual, and when they go through withdrawals, they don't go through withdrawals which require, any IV intervention, such as, IV Ativan or anything like that. And they can handle oral medications and then not prone to having seizures or anything like that, then we can take them. But if it's somebody that is prone to having seizures or pretty significant withdrawals that requires, a hospital setting or an actual detox setting, we wouldn't be able to take them. Individuals have to be able to take care of their own ADLs as well in our adult unit. We are handicap accessible. So if they have walkers and wheelchairs and things like that, we absolutely can handle that. Our bathrooms are handicap accessible. But we have to make sure that individuals can care for their own ADLs. So the other piece too, so majority of the referral for those units do come from the mobile crisis team, but they also come from the hospital settings. So if, there is, I'm just going to say Sarah's team is out there and they're seeing somebody at Beth Israel that they think is a good fit for our CCS unit, they can make a referral directly to our CCS unit. So it is hospital staff as well as mobile crisis teams that can make those referrals. But if you're a provider in the community and you've been seeing someone on a regular basis and you're like, oh, they're not doing so good, and you talk to them about CCS and they're like, yeah, I'm not opposed to doing it, just call the unit, talk directly to the director and say, hey, I have this individual, here's what's going on. I really think that they would benefit from the unit. And then what we'll do is we'll hold a bed until they're assessed and then get them over there. So we get a lot of that from the mental health court in Plymouth. We'll get a lot of calls like, hey, Pam, can you hold a bed? I have this guy. I really want you to see this guy. I think he'll be a good fit. And we work very closely with the mental health court in Plymouth and have done that multiple times for them. So the other piece with mobile crisis is it is 24/7. So we have clinicians available 24/7. It's also 24/7 in our Plymouth site. All 3 sites are open 24/7. The only difference is that our volume in Plymouth on the overnights, unless we're at the hospital, we don't tend to get community cases. We really don't. So what we decided is let's put all of our staff for our Plymouth site in New Bedford. New Bedford's only 25 minutes away from Plymouth. So because we're right off of 140 where our office is. So we have them stationed at the New Bedford site on the overnights, but we have people actually assigned to Plymouth. So if we get a Plymouth case, we actually have security on site in Plymouth. They give us a call and they'll say, Pam, I have John here. He's looking for an assessment. He's here in the office waiting. Clinician dispatches out to the office and meets with the individual. If we had a call from the police department saying that we have a case that we need you guys to come out with, we'll just dispatch right out to that site and meet with the officer there. So the service is exactly how we're doing it in New Bedford. It's just that the amount of volume in Plymouth, it doesn't make sense for us right now to have someone sitting there all night. But when there isn't cases, unless we start to see an increase in volume, then we can have somebody stationed out of that office because we have the staff for it. So it's just a matter of seeing the actual cases come through. So one of the biggest things that also came through the CBHC is getting mobile crisis to do what's called direct admits. Skip the emergency room, because as many of us know, how often we go into the EDs and so many of our patients are in the EDs and they're waiting for hours upon hours. And then you have individuals that are coming in that need some medical intervention, not to minimize the psychiatric component, but they're waiting hours and hours because the EDs are bombarded with patients. I mean, we have patients in the hallways, we have patients everywhere. And the community behavioral health center is designed to be able to see folks in the community, see folks on site, and provide them exactly what we would do in an ED, but in our community site. So the best way to describe it is, if we have a walk-in and that person is evaluated and we determine that they're actually unsafe to be in the community or one of our voluntary units, and they require inpatient psychiatric admission, we don't send them directly to the emergency room. We actually keep them at the CBHC site, which is the mobile crisis a part of it. And we start doing a psychiatric bed search. And once we identify a bed, we just transfer them right from the community site right to the inpatient hospital. Never do they even step foot in the ED. So I am really, really proud of our program and our agency, because on June, everybody's been hesitant. All the mobile crisis teams have been like, I don't know about this. I don't know about this. And on June 1st, I said, let's just do it. Let's try it. We contracted with South Coast Behavioral Health. We came up with a really good medical screening form to get it to work. We knew exactly what was needed to refer them there. And we did our first direct admit on June 1st. And today is September. I don't know which date we're on anymore because everything's blending in. And we have had 23 direct admits. So from June 1st to today, we have 23 patients that never stepped foot in an emergency room and went directly from our community site right to an inpatient psychiatric hospital. The word has gotten out that I got a call from Pembroke saying, Pam, what about us? Why can't you send us patients? Because if you think about it, the patients that are going into these facilities that are hanging out with us until they get a bed that day, you know, they're not throwing things, they're not requiring restraints, they're not requiring IM medications. So for an inpatient hospital, they want those patients. Those are easier patients for them. They're less acuity, even though they require it, right? Because they might have had a suicide attempt or plan to have a suicide attempt. It doesn't necessarily mean that, you know, they're going to be acute in the sense of requiring so much intervention. So they want those patients. So we started with South Coast, we worked our way to Pembroke, and now we've also done it with Arbor hospitals as well. And now we have a Terra Vista and Hospital for Behavioral Medicine really asking us, what about us? Can we get in on this? So we are in the double digits, and we are the only mobile crisis in the state of Massachusetts that's in the double digits. We are actually, I'm going to be presenting to all the Southeast mobile crisis, well, to certain part of Massachusetts mobile crisis teams about our direct admits and why we have such a success rate with it, so that they can start feeling more and more comfortable. And we do the section. We section the individual right off our site, right to the inpatient facility. And we tell the individual that when you get there, you have the right to sign yourself in at that hospital if you want to. You know, you'll meet with psychiatry. You can sign yourself voluntarily in. If you don't sign yourself in, we talk them through. You're held for 72 hours, the 3-day. We go through the whole process with the patients so that they're not blindsided when they get there, and they know that, okay, I never went to the emergency room, but it's still the same exact process when I get to the inpatient facility. The ambulance companies, it was interesting. The first day they came to get a patient, they were like, what do you mean we're going to South Coast? Why aren't we going to St. Luke's? And we're like, nope, you're going to South Coast, and here's your section, here's your paperwork. and off they went. And now they tell us all the time, this is the best experience to come here and get a patient and not have to like navigate through the hallways of the emergency room. You guys have everything all ready for us. We're in and out. It doesn't take long. We had a parent the other day. I stopped into, they were in the we have what's called a living room. All 3 of our sites have it. Where we have like a TV, a kitchen area where folks can feel comfortable while they're waiting. And I had a mom say like, my kid has been inpatient so many times, but this is by far the best experience I've ever had. To be able to sit here with her, watch some TV, keep her comfortable until the ambulance gets here, and she stays in her regular clothes and doesn't have to change into like a green or purple Johnny where everyone knows she's a psych patient, has been an amazing experience. So we've received really great feedback from our patients, and it's been, I'm really proud of the team for doing this and, you know, throwing themselves in there. So we started challenging our Fall River site and Plymouth site to start doing direct admits. We started with New Bedford because we wanted to work out all the kinks and make sure that it worked. We know it works. So all 3 of our sites are ready to go. You know, Fall River just had their first last week. I'm sure Plymouth will have theirs coming up very soon. The more volume we get in the community, the more that we'll start to see these direct admits happen. But yeah, we're really excited about it. The other piece that Mobile Crisis does, and our CBHC piece, is we also do the police co-response program. So we started our first one in New Bedford over 4 years ago. It was really successful. And over a year ago, we started in Plymouth. So we started with Abby. She is there. The running joke, and I tell this to the chief all the time, is the social media for the Plymouth co-response is amazing. But at some point, you might want to let them know that those clinicians actually work for Child and Family. But it's a running joke because everybody seems to think that they belong to the police department. And that's okay, because at least the word is getting out there and they're doing it. So about over a year ago, Abby started, she does 8 to 4 Monday through Friday. And we noticed the volume was really, really high on second shift. She piloted the second shift piece and realized that there was enough volume for another clinician. So we supported another clinician. So we have somebody else there from 4 to midnight as well. So we have 16 hours covered in Plymouth with just the police co-response. And on Friday, they had their 500th call with Plymouth PD. So with that came other towns. So Carver, we just hired our first Carver. It's Carver, Plimpton, Halifax, and Hanson. They have a clinician who is training right now. And then Pembroke and Hanover on Mondays kicked off their co-response program with one of our clinicians, Jillian. So it's definitely getting big. It is a huge benefit to the community and the patients having these programs. And this is all part of the CBHC model and doing community work. So yeah, we're excited.
Yeah, Pam, can I just quickly ask about the co-response? Are these in response to an event that's already happened or a call from the family? What sort of prompts the co-response?
It's the dispatch. So they'll receive a call, and when they're dispatching the officer out to a wellness check, to a substance, an overdose, anything that would fall under the mental health or substance abuse umbrella, that vehicle tends to be the first vehicle to respond. So they'll respond to that case, and then the officer ensures safety. And then once safety is ensured, then the clinician takes over the call.
And it's part of the initial response from the initial dispatch. Wow. Okay.
You got it.
That's
yeah.
great.
So I'm not calling my clinician in Plymouth who's in a cruiser and saying, I need you to go see this case I just got a call from. We completely separate them from the call center so that they're focused strictly on those calls that the police department are getting. And they're busy out there. They're really, even Pembroke, Jillian just started on Monday and she's busy. So we're really excited about it. It's getting really big, but they're doing really good work out there. But the piece about Mobile Crisis is that we can get a referral from anybody. So it could be a family member, it could be the patient directly, it could be schools, it could be psychiatrists, counseling office, but we also get direct calls from the behavioral helpline. So when folks are calling behavioral helpline, which has been really kicked off as well with the CBHC, it's part of the whole CBHC model, and that individual needs a crisis assessment, they do a warm handoff to us. We get a phone call, the individual say, "Hi, Pam, it's Mary from Behavioral Helpline. I have John on the call with me. John is needing to talk to a clinician." Okay, I'll set Mary. I got it. Mary hangs up. I'm on the phone with John. The same thing happens with 988. 988 will do a warm handoff to us as well. But the Behavioral Helpline, the additional piece they do is they can also do a warm handoff to open access. So it's not just mobile crisis, it's also open access. And this is the line in case anyone needs it.
So I'm definitely going to follow up with you. Congressman is going to do an event for law enforcement throughout the whole district about, harm reduction and different types of responses. So I really want to talk about that model, but I'll follow up with you.
Yeah, and I have so much data. It's a we keep data because I feel like it's really important for the data for us to have it. And it is, I think just for an example, in New Bedford, when we started the program, in the first year that they did it, I think the officers only went hands-on one time that first year. Which is huge. It's huge that they're not going hands-on. So there's a huge benefit to this. And we're really proud of the work that they do out there.
So I just want to be mindful of our time, and maybe if we can take a quick pause, if anyone has a question, I know some people need to jump off at 10. Anyone have a quick question or comment? If you do have Amy?
Yeah, I just had a question. So you had said at some point that, they can just, a client could just show up at your site, even in the middle of the night, it sounded like.
Correct.
And so that's accurate. Like, so if I had somebody, I work for the local DV agency, and sometimes we do get people who are, we're not clinicians, we're advocates. So sometimes they need a clinician. And so they can just go to the site in Plymouth.
You got it. They walk in. So Plymouth has the upstairs is where mobile crisis is. That's the 24/7. And then downstairs in the back is open access. So for mobile crisis, there's that we have a ramp. You just go up the ramp. There's a door right there. You ring the bell and someone, security, during the evening, it'll be security. During the day, it's one of our staff that will greet them, make sure go through the safety questions and bring them right in the office with them.
So if it were after hours, we should direct them to the mobile crisis part of it, so not the open access.
Correct. So anything after 8 o'clock is strictly just mobile crisis that's available.
Okay.
But if the person is seen by mobile crisis and they really do need open access, we take care of all of that. We tell them exactly when to come back in the morning. We get it all set up for them so that they're aware of what they need to do the next morning to get the service.
Okay. Thank you. And my other part of the question is, are you open to coming to, say, a staff meeting and doing this presentation?
Absolutely. I can't tell you the amount of presentations I've been doing. That's why I say I don't even go by the PowerPoint anymore, not just for like providers in the community, but statewide. I feel like communities should be really proud of their CBHCs that they have through Child and Family, because we're definitely the front runners of the changes and really embracing what CBHC is and making sure that we're accomplishing what is actually been implemented for our patients. So we're really proud of it. So absolutely, I'm more than willing.
All right, I see your email, so I will email. Thank you.
Any other questions or thoughts? Oh, go ahead, Sheila.
Oh, hi, I'm Pam. Bravo to you and your team. This is just outstanding. Bravo. I really mean it. I've been involved with mental health as a volunteer or family member, and this is the difference between night and day. Okay, it all started back in the, 70s. But one of the questions, this is fabulous. The question, and it comes up a lot, is insurance. If someone comes in, they have no insurance, is somebody there to help them
Yeah.
or direct them to find insurance?
So I apologize that I didn't talk about the insurance piece.
No,
So
no.
for open access, it is a mass health driven product, but mobile crisis is not. So if somebody's coming in and they're uninsured, open access will stabilize, get them what they need, get them set up. We do have groups that we offer to help people to get insurance. But then if that individual needs immediate services, mobile crisis will take over because we can do uninsured. And both of our units can handle uninsured patients as well. So a lot of those, individuals that, one of the biggest pieces that used to be a deficit for us was kids with that, mass health product that was bare bones, that really doesn't cover anything. That's basically uninsured. We couldn't take those kids in our unit. Now we can. We can take uninsured. Mobile crisis is insurance blind. So we are able to see anyone regardless of their insurance. Open access is mass health driven, but they are pushing the insurance companies, the private insurance companies, to see the benefit and how much cost they can, they're actually saving by utilizing open access. So I do think they will jump on at some point and make that change. It's just not happened yet. But that person, like I said, when there's no wrong door, because simply we can navigate once they get there. And we have a group, and I thought it is, I didn't post the groups for Plymouth because I'm waiting for High Point to tell me what they have, but New Bedford has groups as well, which is open to all of our patients, including in Plymouth. And one of the groups does focus on insurance. But I can email you the groups that High Point has for open access as well.
Awesome. Any other questions, comments? There's a lot of information, Pam. We really appreciate it. You tell you've done this before.
Thank you for having me.
Is there any way you can send us the PowerPoint so we can send it out? Because I know sometimes folks like to refer back to it. I know I do.
Yep, absolutely. I'll send it to Karen so that she can share it to you guys.
Perfect. All right. Any other questions, comments? All right, Pam, thanks again. Really appreciate
Thank you, everyone.
Time.
Thank you, Pam.
Bye.
So we do have a time for announcements. I know there's a lot going on now that fall has ramped up, is ramping up. We are co-sponsoring with the Plymouth Public Library and BID Plymouth, the health fair, the Fall Fun Fest. Is that what we're calling it, Karen? Is that right? And that's on September 30th.
Yeah.
Pretty sure that flyer went out, but if anyone on this meeting, on this Zoom today, is interested in hosting a table, they definitely should be in touch with Karen or myself, most directly Karen, because she's really doing all the work for this, which we appreciate. But Karen, you want to talk a little bit about what folks can expect?
Yeah, so I think we've got about 30 vendors so far. We still have room for more if anyone is interested. So it's 10 a.m. to 1 p.m. on September 30th. And it actually is going to happen at the same time as the Farm Day over at the Sheriff's Department. So we're going to be co-promoting a little bit there, hoping to get a lot of families. We've got a DJ, snow cones, for the families, a mobile farmers market. So just a lot of fun. And then vendors, for all ages, different health vendors and social services and all that. So very excited. And it's been a wonderful opportunity to get a little bit more involved, and really appreciate the opportunity. So reach out if you have any questions. I'll put my email in the chat.
Thanks, Karen. Jen.
Good morning, everybody. I just wanted to let you know, if you are interested and available this evening at 7 o'clock at the Hingham Library, the Alzheimer's Association is having a research champion event where we talk about the latest in research, which there has been a lot of good stuff happening in the news lately. So if you're interested in that, join us at the Hingham Library at 7 o'clock. It's about a 45-minute presentation. We also have coming up at the Plymouth Center for Active Living on September 26th at 4 p.m. We have a financial advisor that is going to be presenting about Alzheimer's disease, dementia, really any chronic illness. You know, things change when that comes into play. So looking at the finances, what you might need to put in place, any changes. So that's at the Plymouth Center for Active Living at 4 p.m. on the 26th. And Laurelwood at Pine Hills is going to be providing refreshments for that. And we're able to do all of these education programs at no cost to the communities because we have our Walk to End Alzheimer's, and that's going to be on October 14th at Nelson Memorial Park in Plymouth. Thank you.
It's always a beautiful day. All right, great. Thank you, Jen. Nikki, good morning.
Everybody, good. How are you? Good morning.
Good.
So I just wanted to announce that the Plymouth Sunrise Rotary will be doing their annual Stuff a Cruiser food drive at the Walmart in Plymouth. That's going to be on, I'm looking at my calendar, September 23rd from 10 to 2. So they'll be, the food donations that they'll be collecting will be donated to our food resources program, which folks may or may not know supplies about 60 different emergency food providers throughout the South Shore. So councils on aging, pantries, soup kitchens, Algonquin Heights, all kinds of different folks get food from us. So if we could help spread the word and get folks out to Plymouth so we can have it be a really successful food drive, we would really appreciate it. Summer is always kind of a hard time in terms of collecting food donations. And so we're really needing to replenish our inventory and are really grateful for the timing for the Rotary's Stuff a Cruiser event. So spread the word if you would. Thank you.
Thanks, Nikki. And I did mention that our meeting in October is in person at Salvation Army, and our topic will be food insecurity. In fact, we probably will want someone from South Shore Community Ag, the Food Resources Program, on the panel. So I'll follow up with you, Nikki, on that. There's definitely a lot going on in that space and a lot of need, a lot to talk about. So looking forward to that. Oh. Keep muting myself by mistake. Any other announcements, programs? I know Kim sent out, NAMI has a community conversation coming up. Old Colony Elder Services has a fundraiser coming up this weekend, which are both on your email. Liz Cullen, I'm going to pick on you and have you introduce yourself because I know you're in a new role with South Shore Health, and I wanted to give you a chance to just say hello.
Thank you. Good morning, everyone. My name is Liz Cullen. I am the new Director of Community Benefits at South Shore Health, and this is my first meeting with everyone. So I'm really happy to meet everyone, get to know you, and work together. Everyone that I've talked to over email has been super welcoming, and I'm looking forward to it. This is my 4th week, so I'm very new, but I'm learning a lot, and I'm looking forward to interacting with everyone.
Awesome. Thanks, Liz, for being here. Really appreciate it.
Thank you.
And my last Kim sent out announcement today is that Kim sent out a survey, which the steering committee came up with for the membership about timing, place of meetings, Zoom versus in person, days that are better. Seems like Wednesday mornings work pretty well for us, but we want to make sure that works for as many people as possible. Also sort of what the Chana means to you and what you get out of it, and helping to guide our future, so to speak. So if folks want to take a minute to fill that out and get it back, we'd really appreciate it. And sadly, not only is that my last Kim sent out announcement for today, it's my last Kim sent out announcement ever, because unfortunately Kim is taking a new position outside of the United Way. So we are saying goodbye to Kim, very sadly. She's been the coordinator for this Chana for the last 8 years, I think, Kim. Did we figure that out? 8 or 9 years? Pretty close to it. And Kim reminded me today to start recording. Kim reminds me every general meeting that I have to record it. Kim posts the recordings, Kim sends out the emails. So if you don't hear from us for a little while, you'll understand why. But hopefully we'll have a seamless transition to our new coordinator. But I just want to take a minute. I wish we were in person so we could thank you in person, Kim. But on behalf of the Chinar and myself, being the chair during your entire tenure, we really appreciate all you've done, and you've been an integral part of this group, and we will definitely miss you. So thank you, Kim.
Thank you so much, Mike, and thank you to everyone. It's been such a fun time working with this group. And the good news is you'll get some Dennis Carmen, for those that know Dennis, for a little while my replacement is hired. So that's a silver lining there. But yes, I appreciate everyone's well wishes very much, and we will keep the Chinar in good shape. And I'm not going anywhere. I still live in the community, so I hope to be able to participate and visit from time to time.
Yeah, we were joking during steering committee because we're kind of expanding onto the Cape and Islands and maybe Greater Taunton. And Kim's new job is in Dover. So I said, oh, we'll take Dover over too, and make Kim keep coming to our meetings. So manifest destiny. We're going to take over the whole state.
Thanks, Mike.
All right.
And just a quick note, I know you mentioned the website, but the website is under construction right now, but the Gmail is still up and running, so that chinar23@gmail.com is the best way to get in touch with us while the website is being refreshed, which should be a great benefit for the group in the next month or two.
Yeah, and probably should highlight that we still will have a grant program this year. We have, I think, did we lower the amount, Kim, to 2,500? Yeah,
that's right, 2,500 for the mini
grant. It had been 3,500 as a max. Max now is 2,500, and we're on the same schedule. There'll be 2 grant cycles, one in December and one in April. So we'll send out info on that so people have it, but hopefully the website will be up before then. But I know a lot of people go to the website to find out when the next grant is. So just make a note of that. The next grant cycle is in December. All right. If there are no other announcements or programs, I would entertain a motion to adjourn. Karen, thank you. Is there a second? Amy, thank you. Any discussion? All in favor? And look, we're ending right at 10:15. That's a sign of a great leader, ending the meetings on time, right? Thank you all. Great to see everyone. Hope to see you on September 30th at the Fall Fun Fest, and hope to see you on October 13th? No,
11th.
October 11th, which will be our in-person meeting at the Salvation Army on Long Pond Road. Thanks, everyone. Have a great day.
Thanks, Mike. Thanks, Kim.